Edrophonium. We don't really use this a whole lot anymore because there are better tools, but you know, my pharmacology exam likes to have things that are obsolete on it. So this is used to diagnose myasthenia gravis, and they use this because it is an anticholinesterase, an antidote, and a muscle stimulant. And if you give this and the symptoms improve, that might tell you that the crisis you're in is a myasthenic crisis because it'll get a little bit better. But if it's a cholinergic crisis, it's going to get worse because this is a cholinergic or an anticholinesterase medication. Just happens to have a really fast half-life, so it doesn't last very long, but it can still be dangerous. Some adverse effects include abdominal cramps, anaphylaxis, bradycardia, cardiac arrest, arrhythmias, dysphagia, increase in tears and sweat and secretions, meiosis, urinary frequency, and incontinence. It interacts with corticosteroids and succinylcholine, and the nursing considerations include giving slowly, have your atropine ready, and it may make your patient worse or scare them. As it turns out, Edrophonium is FDA approved for use in the reversal of non-depolarizing muscular junction blocking agents after a surgical procedure. Nonetheless, we still prefer the neostigmine, and it's used way more often than Edrophonium. Remember that using this drug is considered the Tensilon test if you're going to use it for trying to figure out a myasthenia gravis crisis. It has a very rapid onset of about 1 minute and lasts about 10 minutes. Remember, if it makes these symptoms worse, then you're going to scare the daylights out of your patient. It's probably not the best thing to do. Never ever use this drug in patients with GI or urinary obstruction. I probably already said that, but let's just make sure we don't do that. You probably don't want to do it if you have an arrhythmia or asthma either, so choose something different.